Kanski lecture series, chapter 9, Episclera and Sclera, part 3. And in this part we are going to discuss about the important systemic associations of scleritis. As we have discussed earlier, the scleritis is most commonly associated with the systemic inflammatory disorders and very rarely with the infective disorders. So whenever a patient of the scleritis comes to you, you have to rule out the systemic associations of scleritis, systemic inflammatory disorders. First of all, most important, rheumatoid arthritis. The autoimmune disease rheumatoid arthritis RA is the most common systemic association of the scleritis, as it is characterized by the symmetrical deforming inflammatory polyarthropathy with a spectrum of possible extra-articular manifestations. Presentation is commonly in the third decade with joint swelling usually of the hands. So very important, what happens is there is a swelling of the small joints of the hands. Most commonly fingers are involved and there is a swelling of the joints. And multiple joints are involved in these cases. It is much more common in females than males, so you will mostly see a female of rheumatoid arthritis is very common in females. Rheumatoid factor autoantibodies are present in 80 to 90%. All forms of the immune mediated scleritis have been described in rheumatoid arthritis, and the clinical course is often aggressive than when there is no systemic association. So if the clinical course, when it is more aggressive, when there is no systemic associations. Other ocular manifestations of the rheumatoid arthritis include keratoconjunctivitis sicca, secondary Sjogren syndrome, ulcerative keratitis, and acquired superior oblique tendon sheath syndrome, very rare. Tip: rheumatoid arthritis is the most common systemic association of scleritis and can manifest with any forms of the immune mediated scleral inflammation. So what are the systemic ocular manifestation of rheumatoid arthritis? Very important: dry eyes, PUK. You must remember at least these three: scleritis, and then there is a superior oblique tendon sheath syndrome. So you can see this figure 9.13, important systemic association of scleritis, rheumatoid arthritis, showing ulnar deviation in long-standing disease. So these are when there is a long-standing disorders. Rheumatoid nodules, so these are nodules, rheumatoid nodules. C is showing granulomatous with polyangiitis, showing nasal collapse and convergence squint secondary to extensive sinus disease. So there is a sinus disease which is causing the convergent squint and the nasal collapse. D is showing the erythematous papule and bullae, typical of small vessel vasculitis. E is showing relapsing polychondritis, showing swelling of the pinna. So this is a pinna, the external ear. F is showing the saddle-shaped nasal deformity. So next is granulomatous with polyangiitis. Very important. It is very important in ocular. You must know about all the ocular manifestations of the granulomatosis with polyangiitis. Very important. And one of these is in orbital inflammatory disorders. Granulomatous with polyangiitis. Granulomatous with polyangiitis vaginal granulomatosis is an idiopathic multi-system granulomatous disorder characterized by the small vessel vasculitis, typically affecting primarily the paranasal sinus. Very important. Whenever a patient comes with a certain kind of sinus disease and it is now affecting the eyes, you must always think of vaginal granulomatosis. Lower respiratory tract, the kidneys and the skin. There is a male predominance. Presentation is in the 5th decade on average, often with pulmonary symptoms. Anti-neutrophilic cytoplasmic antibodies C and K are found in over 90% of the patient with active disease. Very important with the MCQ's point of view as well. Scleritis is often rapidly progressive, necrotizing, and granulomatosis. Other ocular manifestations include peripheral ulcerative keratitis, occlusive retinal vasculitis, orbital inflammatory disease, nasolacrimal duct obstruction, decrucistitis, and rarely tarsal conjunctival disease. Relapsing polychondritis is a rare idiopathic condition characterized by the small vessel vasculitis. So it is a inflammation of the small vessel involving the cartilage, resulting in recurrent, often progressive inflammatory episode involving multiple organ systems such as ear, nasal cartilage, respiratory system, hearts, and joint. So polychondritis means it will affect the multiple cartilages like ears, nasal cartilage, respiratory system, hearts, and joints. Presentation is frequently in middle age. Scleritis is often intractable and may be necrotizing or non necrotizing. So, isolated anterior uveitis may also occur. So, scleritis is very common and it can be necrotizing and non necrotizing, and anterior uveitis may also occur. Polyarthritis nodosa. Polyarthritis nodosa is an idiopathic aneurysmal vasculitis affecting medium sized and small arteries with a wide range of manifestations across the multiple organ system. So, it is all the multiple inflammatory disorders. It is involving the medium size and the small arteries. Presentation is in third to sixth decade, often with the constitutional symptoms. The male to female ratio is 3:1. It is also male predominant. Polyarthritis and polyangiitis are male predominance. Ocular involvement may precede the systemic manifestations by several years. About one third of the patients have hepatitis B infection. Scleritis is often aggressive and necrotizing. Peripheral ulcerative keratitis, orbital pseudotumor, and occlusive retinal periarteritis are other reported ocular features. So, very important for the MCQ's point of view, you must remember which surface antigen is positive in case of the polyarteritis nodosa. Hep C surface antigen. So next is the Crohn disease. Crohn disease is basically an inflammatory bowel disease in which there are two types of inflammatory bowel disease: Crohn disease and ulcerative colitis. So Crohn disease, which involves the mouth and up to the small intestines. Crohn disease is a chronic relapsing inflammatory bowel disease of unknown cause. Extraintestinal complications occur frequently during the course of the disease. The commonest of these are peripheral arthritis and erythema nodosum. The eye is involved in 4 to 10% of the patient, and wide spectrum of inflammatory condition may be found. Acute episcleritis, acute anterior uveitis, and marginal keratitis are the common manifestations, although conjunctivitis, optic neuritis, orbital inflammatory disease, and retinal vasculitis have been reported. Basically, in this case, you must remember about acute episcleritis and acute anterior uveitis. Acute anterior scleritis is rare and may be complicated by the development of scleromalacia perforans. What is scleromalacia perforans? It is a necrotizing scleritis without inflammation. Acute episcleritis and increased bowel activity show a close correlation. So next is a treatment of the immune-mediated scleritis. Immune-mediated scleritis is topical steroids. So basically, with the immune-mediated scleritis, you have to give anti-inflammatory things like steroids. You can give biological blockers. You can give immunosuppressants like azathioprine, like this. Topical steroid, and of course you have to treat the systemic disease as well. Topical steroid do not affect the natural history of the scleral inflammation but may relieve symptoms and edema in non-necrotizing disease. So very important, you have to give it in the non-necrotizing disease. Systemic NSAIDs should be used on their own only in a non-necrotizing disease. It is often necessary to try a number of different drugs before finding one that provides adequate relief of symptoms. A cyclooxygenase is the COX-2 inhibitor may be preferred in elderly patient or if there is a history of a peptic ulceration but can result in cardiovascular side effect. Patient should be warned of the risk of gastrointestinal tract hemorrhage. So COX-1 and COX-2. Basically, COX-2 only affect the inflammatory disorders, whereas COX-1 also inhibit the enzymes in the stomach, so it can cause ulcer formation. So that is why we do not give away COX-2 is preferred one. Periauricular steroid injection may be used in non-necrotizing disease, but their effects are usually transient and should not be used in necrotizing scleritis. So these are all disease treatment that is involved in non-necrotizing scleritis. Systemic steroid, for example, prednisolone 1 to 1.5 mg per kg per day are used when NSAIDs are inappropriate or inadequate. Necrotizing disease. Intravenous methylprednisolone 0.5 to 1 gram daily for 3 days may be used initially for severe cases. So pulse therapy is used when there is a very severe disease, and how we give it, we give 500 milligram to 1 gram of it for the consecutive 3 days, and then we shift to the oral steroids. Immunosuppressive or immunomodulatory agent should be considered if control is incomplete without steroid alone, or as steroid sparing measure in a long-term treatment, or to treat the underlying systemic disease. Patient with scleritis secondary to the following condition: granulomatous with polyangiitis, polyarthritis nodosa (RA) with necrotizing scleritis, and relapsing polychondritis should be offered immediate treatment with immunomodulatory agents. A wide range of drugs are available, including cytostatic, cyclophosphamide, azathioprine, methotrexate, drugs acting on immunophilins, for example, cyclosporine, tacrolimus, and biologicals. In necrotizing disease, rituximab is particularly effective. Very important line, rituximab for the necrotizing disease. Tip: rituximab is particularly effective in the treatment of necrotizing scleritis. Porphyria, very important. Porphyria is a case where you will often see a case of the scleritis because the UV radiation is very sensitive to the area, to the exposed area. As eyes are exposed to the sun, it can cause the scleritis in it. Scleritis is a rare complication of the congenital erythropoietic porphyria and two of the adult form of porphyria, porphyria varigata and porphyria cutanea tarta. So of course there are two types of porphyria, congenital and acquired. Acquired has adult forms are two types, that means porphyria varigata and porphyria cutanea tarta. Basically it is differentiated on the basis of the enzyme that is defective and that is causing the overproduction of the porphyrins. Overproduction and excessive storage of the porphyrins occur in liver. These highly photoactive chromophores are also deposited in the dermis and sclera, which are subsequently stimulated by the exposure to the sun. The sclera become thin or excavated over a sharply demarcated area localized to the sun exposed interpalpebral region adjacent to the cornea. Acute diffuse anterior scleritis and posterior scleritis may occur. Patient should avoid sunlight and undergo phlebotomy. Basically, what is it saying? Porphyrins are basically compounds that are deposited in the sclera and dermis. And what happens is when the sun is exposed, they are produces burning. So that is why it causes the thinning of the sclera and there is a scleritis. Now, very important, infectious scleritis. Infectious scleritis, basically you know that some infection is the cause of it, but it is very rare. Infectious scleritis is rare but may present diagnostic difficulty as the initial clinical features are similar to those of immune mediated disease. In some, infection may also follow surgical or accidental trauma, endophthalmitis, or may occur as an extension of the corneal infection. So corneal infection can cause scleritis, endophthalmitis can cause scleritis trauma and something like that. So this is a figure that is showing scleral involvement in porphyria. It is showing the acute involvement and it is showing the chronic scleral thinning. Herpes zoster is the most common infective cause. So as I told you earlier, especially in the case of nodular scleritis, herpes zoster is very important. Herpes zoster is the most common infective cause. Necrotizing scleritis is extremely resistant to treatment and may result in a thinned or a punched out area. Tuberculosis scleritis is rare and difficult to diagnose. The sclera may be infected by direct separate from the local conjunctival or choroidal lesion, or more commonly by hematogenous spread. So how does it got affected? Tuberculosis sclera, hematogenous spread, or from the choroidal lesion. Involvement may be nodular or necrotizing. Leprosy, recurrent necrotizing scleritis can occur even after apparent systemic cure. Nodular disease may be seen in lepromatous leprosy. Syphilis, diffuse anterior scleritis may occur in secondary syphilis, and occasionally scleral nodule may be a feature of tertiary syphilis. Lyme disease scleritis is common but typically occur long after initial infection. Other causes include fungi, Pseudomonas aeruginosa, and nocardia. Treatment: once the infective agent have been identified, specific antimicrobial therapy should be initiated. Topical and systemic steroid may also be used to reduce the inflammatory reaction. If appropriate, surgical debulking can be used to debulk a focus of infection and facilitate the penetration of antibiotic. So very important, there are certain infectious disorder that causes scleritis, herpes zoster, tuberculosis, leprosy, syphilis, and Lyme disease. One thing you must remember is that herpes zoster is the most common and infective cause. Scleral discoloration. So there are certain feature that is causing the discoloration of the sclera, and so here it is showing infectious scleritis. A is showing acute inflammation in herpes zoster. B is showing the focal necrosis secondary to herpes zoster. C is showing nodular tuberculosis disease, nodular scleritis, and Lyme disease. Alkaptonuria. Basically, these are all metabolic disorder. There are certain enzymes that are deficient, and that is causing accumulation of certain products that is causing the disease. Alkaptonuria, it is in this autosomal recessive condition, a defect in a homogeneous acid oxidase result in accumulation of the homogenetic acid in a collagenous tissue such as cartilage and tendon. Ochronosis. Ocular manifestation include bluish gray or black generalized pigmentation of the sclera and the tendons of the horizontal recti associated with discrete pigmented globule. Systemic features include dark urine and arthropathy. So very important. So this is alkaptonuria. Pigmentation, this is ochronosis of the sclera and horizontal recti of the blackish deposition of the things. B is showing the dark urine with normal for comparison. So this is a alkaptonuria urine. Hemochromatosis, iron, basically iron is deposited in it. The systemic features of the hemochromatosis are caused by the increased iron deposition in various tissue. Features may be more subtle, but the classic triad of bronze complexion, hepatomegaly, and diabetes. So hematochromatosis triad, you should remember: bronze complexion, hepatomegaly, and diabetes. Inheritance is autosomal recessive. Dry eye and rusty brown perilimbal conjunctival and scleral discoloration may develop. Rusty brown. Blue scleral discoloration is caused by thinning or transparency with resultant visualization of the underlying uvea. Major associations are discussed below. So whenever the sclera is thinned out or transparent, it causes the exposure of the underlying uvea, which gives it a blue color. Major associations are discussed below. Rare associations include Marshall-Smith syndrome, in which there is an accelerated prenatal skeletal maturation and growth. Russell Silver syndrome, short stature, and other features, and Hallermann-Streiff-Francois syndrome. So these are some rare disorders that are associated with it, but most important are osteogenesis imperfecta and Ehlers-Danlos syndrome type 6. Osteogenesis imperfecta is an inherited disease of connective tissue, usually caused by a defect in the synthesis and the structure of the type 1 collagen. So, what is defected in osteogenesis imperfecta? Type 1 collagen is synthesis is defective. There are multiple types, at least two of which are ocular features. So, two have an ocular feature, type 1 and type 2A. Type 1 is an autosomal dominant. Patients suffer few fractures with little or no deformity, hyperextensible joints, dental hypoplasia, deafness, and easy bruising. Possible ocular features include blue sclera, megalocornea, and corneal arcus. So remember that they're thinned out. Everything is becoming thin and long. So whenever everything is becoming thin and long, blue sclera will develop, megalocornea will develop, corneal arcus will develop. Type 2A is either sporadic or inherited in an autosomal dominant manner. Systemic features include deafness, dental anomalies, multiple fractures, and short limbs with death in infancy from respiratory infection. Ocular manifestation include blue sclera and shallow orbit. Ehlers-Danlos syndrome type 6, ocular sclerotic, is an inherited disorder of collagen formation. So it is also an inherited disorder of collagen formation. Patient have thin and hyperelastic skin. Skin is hyperelastic and thin that bruises easily and heals slowly. The joints are hypermobile, which may lead to recurrent dislocation and fall. Cardiovascular disease can be severe, including bleeding, diathesis, dissecting aneurysm, and spontaneous rupture of large blood vessels and mitral valve prolapse. There are 6 major types, but type 6 and rarely type 4 are associated with ocular features. As well as blue sclera, other manifestation include scleral fragility, globe rupture, may be caused by mild trauma, epicanthal fold, microcornea, keratoconus, keratoglobus, ectopia lentis, myopia, and retinal detachment. So in these cases, basically there is a collagen formation deficiency, and that is why the everything is becoming long and thin. Miscellaneous condition: congenital ocular melanocytosis. Congenital ocular melanocytosis. So basically it is a type where the sclera is having a blackish in color, and there is an increase in pigmentation of the sclera. Congenital ocular melanocytosis is an uncommon condition characterized by increase in the number, size, and pigmentation of melanocyte in the sclera and uvea. So everything is increasing in size, number, size, and pigmentation, sclera and uvea. The periauricular skin, orbit, meninges, and soft palate may also be involved. Ocular melanocytosis, the least common, involves only the eye. Multifocal slate gray pigmentation is seen within the sclera and episclera. The process does not involve the overlying conjunctival layer unless there is an incidental conjunctival pigmentation. The overlying conjunctiva is mobile over the episcleral pigmentation, but the pigmentation is itself intrinsic and cannot be moved over the globe. The peripheral cornea is occasionally involved. Dermal melanocytosis, 1/3 only involves only the skin. Ocular dermal melanocytosis, very important. It is also known as nevi or phota, in which both the eyes and the dermis is involved. It is the most common types and involve both our skin and eyes. Nevus of phota is bilateral in 5%. Bilateral. It occurs frequently in the darker complexioned orifices, but is rare in white people. There is a deep bluish hyperpigmentation of the facial skin, most frequently in the distribution of the first and the second trigeminal division. It may be subtle and pale skin individual when it is best detected under the good lighting. So you can see this is a 9.18 showing the systemic association of blue sclera. A is showing the multiple fractures in osteogenesis imperfecta type 2A. Continuous cutaneous hyperelasticity, joint hypermobility in Ehlers-Danlos syndrome, and this is showing congenital melanocytosis. A is showing the episcleral melanocytosis, and B is showing the cutaneous melanocytosis in the nevi of the aorta. 9.20 showing the ipsilateral association of the nevi of the aorta. A is showing the iris heterochromia, so you can see the difference in the color of the both eyes. Iris mammillation, so there is a small mammilli formation in it. C is showing the fundus hyperpigmentation, and D is showing the trabecular hyperpigmentation. So these are all features of nevi of aorta. Ipsilateral association include iris hyperchromia is common, iris mammillation are uncommon, tiny regularly spaced villiform lesion. They may also be found in the neurofibromatosis type 1, Axenfeld-Rieger anomaly, and Peters anomaly. So very important, you should remember in which cases you find iris mammillation: nevi of aorta, NF1, Axenfeld-Rieger anomaly, and Peters anomaly. Fundus hyperpigmentation, trabecular hyperpigmentation, this is associated with glaucoma in about 10% of the cases. Uveal melanoma develops in small minority of the patients, and long-term anterior and posterior segment review is required. So uveal melanoma is also very common. Patients with oculodermal melanosis are at risk of developing glaucoma and occasionally uveal melanoma. Idiopathic sclerocoroidal calcification. Idiopathic sclerocoroidal calcification is an innocuous age-related condition that usually involves both eyes of the affected older adults. Geographic yellow-white fundus lesions with ill-defined margins, often multiple, and located in the supratemporal or infratemporal mid-periphery associated with vascular arcade. So you can see 9.21a, it is showing the idiopathic sclerocoroidal calcifications. So it is located in the retina. Yellowish white lesion. It is mostly located in the mid-periphery. Ultrasonography show highly reflective choroidal plaque-like lesion with orbital shadowing. Of course, whenever there is a calcification, there is going to be the shadowing of the lesion. Differential diagnosis is mainly from the osseous metaplasia associated with choroidal hemangioma and from choroidal osteoma, which is usually single of a large lesion that usually 80 to 90% involve only one eye. Scleral hyaline plaque and senile scleromalacia. Very common scleral hyaline plaque, you will often see there is a brownish patch like thing that is basically at the insertion of the tendon. Scleral hyaline plaque are the oval, dark grayish, jelly sharply demarcated area located close to the insertion of the horizontal rectus muscle. Senile scleromalacia are referred to the spontaneously. So you can see figure 9.22. So you can see this is a hyaline plaque, and you can see that it is involving the tendon of the recti. Senile scleromalacia refer to the spontaneously occurring irregular oval or kidney-shaped partial thickness scleral defect found at the same location, typically with one or more scleral hyaline plaque at the opposite location in the same eye or in the fellow eye. Separation of the scleral hyaline plaque to leave an area of a scleromalacia has been described. Both these entities typically affect elderly patients and are innocuous and should not be confused with scleromalacia perforans, which occur in somewhat younger patients, may be located anywhere in the anterior sclera and is not associated with hyaline plaques elsewhere, and can progress to full thickness scleral defect with uveal exposure. So, senile scleromalacia is basically age-related, in which there is a thinning of the sclera with the senile plaque. So that's it for the chapter 9 of the Episclera and Sclera. We'll see you in the next lecture. Thank you very much.